Glad to see so many of you here today to learn, laugh, and network with each other. Before we begin, I have a few things to say is that this training is being videotaped. So please be mindful of noise, distractions while the training is being recorded. Please place your cell phones on courtesy mode. Restrooms are located down the hall. There is 12 social work CEUs available for this training. We had to expedite the process again, and again, we're so glad to see everyone here, but during break you can go back and sign in. Please put your social work license number on there. If it's not indicated, then when it gets turned in, you will not get credit. So I'm going to begin by saying, why are you here today? The Department of Human Services has been asked by the Centers for Medicare and Medicaid to develop a curriculum to ensure that there's consistent practice and knowledge for case aides, now to be referred as mental health technicians that serve needs of vulnerable populations. CMS has been assured by the Medical Services Division that all mental health technicians will receive training to become certified. This is part of this Medicaid state plan amendment that has been submitted to CMS. We are very fortunate over the next 2 days to have several experts present information to you on several different topics. These topics will provide a basic knowledge and overview on a wide array of mental health, cultural competency, child welfare, addiction, court, and family-driven services to meet the individualized needs of those you serve. With that, I would like to introduce Lauren Sauer, who will be reviewing your agenda and the evaluation today.
Good morning, everybody. The agenda can be found in the front of your training manual. As you can see, the agenda is broken into 5 units. Information for each unit can be found in the manual under the corresponding tab. We will begin this morning with Unit 1. Dr. Lisa Hay will provide training on signs and symptoms of mental health disorders. At 11:15, Sandy Thompson will present on addiction and mental health. Finishing out the morning will be Dawn Bonner with a presentation on evidence-based and promising practices in mental health. At noon, we will break for lunch. Lunch will be on your own. This afternoon, we will start with Unit 2 at 1 p.m. Dawn Bonner will continue with a presentation on the recovery model and person-centered treatment. Don Krieger will follow with a presentation on wraparound and partnerships. At 1:30, Marlis Baker will talk about child abuse and neglect. And following our afternoon break, Lorena Poppy will present on the Protection and Advocacy Project, followed by Carlotta McCleary speaking about the Federation of Families for Children's Mental Health. At 3:45, Tara Mulhauser will present on testimony for courts. And Cherry Schmidt will close the day with Unit 3, documentation. We will then adjourn at 5 p.m. We will start on Wednesday at 8 a.m. Unit 4 will start with a presentation on cultural competence with Dale Tweet. At 10:15, we will continue with a presentation by Sandy Iverson on Native American cultural competency. At 11 a.m., we will start Unit 5 with a presentation on crisis intervention, therapeutic communication by Lyndon Ring. That will be followed up with a presentation by Kurt Peacock on universal precautions. At 11:45, you will complete the open book evaluation. You should have picked that up as you came in as part of the handouts. The training will then conclude around noon. As I just mentioned, the evaluation is open book. There are 20 multiple choice and true or false questions, each worth 5 points. The evaluation is pass-fail. You must get at least 14 questions correct in order to pass. The evaluation must be turned into Carla at the end of the last day of training and receive a passing score and you must have the prerequisites completed to be certified as a mental health technician. A provisional certificate will be provided to those who do not have the prerequisites completed and to those who are not able to attend today's training. The division will have copies of the video made and dispersed to the Human Service Centers to provide to those agencies that provide mental health technician services. The provisional certificates are valid for no more than 90 days. If you have any questions concerning the requirements for certification, please feel free to talk to Carla or me during the breaks. It's now my pleasure to welcome our first speaker, Dr. Lisa Hay.
Hi. We get to talk about mental health diagnoses today. The excitement mounts. Woo. Can y'all hear me? All right, I have about 6 accents. I'll go through them all for you. I travel a lot. Woo. You all have a handout, which I did not anticipate you having, so I know most of you will be reading. Feel free to read ahead, then you can be bored with me later. Oops. Uh-oh. See, I've already hit the wrong button. Help me. Lauren, help me. Does anyone know how to get out of here? Nope. All right. Well, there's a second one. I did. Oh, there it goes. Thank you. 2 clicks. There we go. All right. I got them backwards because, yes, I am a PowerPoint person. There we go. All right. So what we're looking at with you all is client needs and the trouble with troubles. And that basically is talking about mental health disorders and the fact that no one really wants them, that they cause a lot of grief for the person that has them, and the person that has them can in turn cause you guys a lot of grief. So that's where the mentor-caregiver needs come in, is getting a lot of support. Oh, whoops. Sorry. All right, I'll hold it. Is that better? No, it's off now. All right. Well, I didn't touch it this time. Hello. Technical difficulties. Does anyone know where to turn it on?
Let me see.
I'm going to use my outdoor voice.
Yeah.
All right. So, all right. Where are we? All right. The people with the mental health illnesses are having troubles. That's why they have you guys. Most people with mental health illnesses either have medication, or they have therapy, or they have medication and therapy. If you guys are meeting them, they also need to have a case aid, mentor, mental health professional. Pay attention behind the man behind the podium. So that means they're having more severe needs. My understanding is that you all are the mentors that deal with the kids, and that you also are the case aides that go in the homes and help the people out. Is that correct? Are there some of you that do residential stuff as well? Yes. Okay, there we go. So that's good. At least I know who I'm talking to. If you have questions, please ask them. There is nothing known as a stupid question, all right? Because if you don't ask, you won't know. I tend to talk fast. I tend to get nervous and get a southern accent. These are the things you have to watch out for with me. It's important for you all to know that you are a very vital part of the team, and that a lot of times your input is what's needed, because you guys are the ones that are going to see these people more often. You're going to see them in their home environment, and you're going to see them on the daily, on the wards. So you're going to see them more acting out. You're going to see what hallucinations are going on for the people if they have hallucinations. So it's important that you let your supervisors know if the person's changing, so that their therapist can know. If you have direct access to the therapist, that's even better. But whatever, you guys, I don't know which power system you all are working on. All right. Oh, I could flip. Oops. Okay, so we're going to become familiar with some diagnoses. And that's the questions. Ask questions of me and ask questions of your supervisors. Why do we diagnose? Many people think we diagnose just so that we have a language to talk to each other about so that other people listening to us can't understand us. That is not actually true. It's to give us a quick and dirty view of the basic issues of what the person is going through. We go through our am I talking loud enough for y'all in the back? Or are y'all drifting? All right, we have here the DSM-4, sorry for you in the front. We have the DSM-4, which is what we look at to find out what symptoms people have is from talking to them. Then we look in our book to see if their symptoms match a particular diagnosis, and if so, which diagnosis or diagnoses. It's like if you are sports fans and I say to you, I am a cheesehead, then you all know a couple of things about me immediately. True? What do we know? Yes, Wisconsin, Packers, and I probably wear green, right? We do not know if I am a full-blown cheesehead and will wear a cheese hat. We do not know if I will only wear discreet little Packer earrings. We do not know if I hate the Vikings or if I simply think they are stupid, right? But we do know a few things just from my saying cheesehead. Same thing goes with major depression. If I say someone has major depression, then you all know that they are probably not happy, right? So it gives you a category so you can have a quick visit of what's happening for that person. Does not tell you every detail, okay? Basically, this is a cookbook. So there are some ingredients that they have to get a diagnosis, and then there are different variations of the symptoms that they could have. So each person still is an individual and may present differently. Some people have laughing depression where they giggle a lot, but on the inside they're crying. Some people give you the nice classic sadness to view, okay? So that's kind of the quick and dirty version of that. Oh, shorthand. There we go. Boop. All right, we're going to go through mood disorders, anxiety disorders, psychotic disorders, personality disorders. Personality disorders we're just going to touch on. That's a whole day. Childhood behavioral disorders, and pervasive developmental disorders, and mental retardation, and learning disorders. Yay! That is this morning's activity list. So yeah, I'll be talking fast. There are depressive disorders, bipolar disorders, and other mood disorders, all in the family of mood disorders. All right, so what symptoms do you guys expect when you hear depression? Feel free to call out from the back because I cannot see you in the back, and so you will still have your anonymity. I can't even say the word, but you know what I'm saying. Sad. Moody. Cool. What else you got? A Packers fan. Suicidal and a Packers fan. Suicidal. All right. Any other symptoms you think of when you hear about depression? Lethargic. And there was someone else that spoke, but I didn't hear you. I'm sorry. I'm sorry? Anger. Thank you. All right. Cool. All right. Women are diagnosed with depression a lot more often than men. There's a combination of factors that probably go into that. One is that women are a lot more likely to admit they're feeling sad. Men are a lot more likely to switch it fast to anger, or to just feel like perhaps they have the flu. They've had the low-grade flu for the last 6 months since their dog died. Isn't that interesting? You know, some of it's self-awareness, some of it's hormonal factors. If you want to have fun, raise your adolescent children at the same time that you are going through menopause. Always recommended. Face additional stress at work and home because a lot of times, no offense to the men folk, but the women tend to do more at the home than the men still. So you have your full-time job, plus your full-time mothering, plus your part-time help from your husband. Now, of course, you men are doing much better, but not 50-50 yet. Many women are also vulnerable after birth of the baby. We have our ever-popular Brooke Shields, who did a real good job with postpartum depression and letting people know about that. Exactly. Doop. You guys are part of the treatment staff. You are the support crew for the people with the depression. You're the ones that are helping them get out and still do some things so that they can get their endorphins running around so they can help fight the depression. You're the one that's there to help them talk a little bit about their problems and figure out what they want to do with their lives and how to get out of it. Depression in men, even though there's twice as many women, look at that, 3 to 4 million men. So that must mean 6 to 8 women. So there you are. Men are less likely to admit it. Yep, we got that. Suicide rate, men are lethal. If a man talks about suicide, take it twice as strongly as you do with a woman talking about it. We women are more likely to seek help and talk about it faster, so we're not as deeply saddened and we're not quite as ready to be lethal. A man is a lot more likely to bottle it up, talk about it when he's got the gun to his head. Okay? So when someone talks about suicide, use your cell phones, call somebody, get somebody over there to help out. You know, usually your supervisor should let you know. Lisa always talks about suicide. This is what we do when she's talking about suicide to help me calm down, all right? These are the signs when Lisa's going wacko and you really are going to have to call me in and it's probably an emergency, call the cops, get her some help, all right? If you talk to one of your clients and you're nervous, talk to your supervisor. That's what they're there for. Talk to whoever's available, a therapist, whoever. It's no problem to bring to the attention, all right? If they give you the poo-poo sign, tell them to eat dog do. Honestly, it's never a poo-poo thing. If you guys have a question, it's always legitimate to bring it up, okay? And some of us, we get old and crotchety, that would be me, and we get a little gallows humor going on, so you say to us, oh, they're suicidal. I'm like, oh, really? Okay, I am not, oh, really to you. I am, oh, really to that person because I've known him for 6 years, okay? But I shouldn't say, oh, really like that to you guys because then you might feel dissed, all right? And I do not want to discount you. So tell me to mind my manners, all right? Let's see. Boop. Oh, stuffing is not good for your heart. Men, feel free to talk about your feelings. All right. When you do an intake, you always ask about family history, and the reason you're asking is that genetics play a big role in alcoholism, addiction, depression, and anxiety, and all the mental health disorders. There's a combination of the genetics and the family upbringing, okay? If it's modeled for me that when I'm sad, I'm supposed to punch people out, I'm more likely to be an aggressive person. If it's modeled when I'm sad, I'm supposed to become suicidal, I'm more likely to be suicidal. Plus, on top of it, I've got the genetics from my family, so depression may run in my family. Those are good things for the therapist to know, and they should be passing the dirt on to you guys about what kind of things to do with your peoples. Your peoples. All right. The neurotransmitters, they're talking about your level of dopamine and serotonin and what's going on with that. What you have is regular happy life, la la la. Then you have broken up with my boyfriend of a week. Oh, how sad I am. But not super sad. All right, then I'm super duper depressed, and no matter what I do, it doesn't seem to help. I go for the walks, I talk to you guys, I talk to my therapist, and yet I still remain down here. I'm the person that's going to get on the medication. Then I'm going to get the medication, it's going to take me up to here, the counseling and the help from the case aides and the mentors is going to get me up to there. Does that make kind of sense? And that's the neurotransmitters. Some people have to be on antidepressants for life. Some people only have to be on antidepressants short term. It depends on their bodies and what happened, okay? Any questions? All stuff you already know. Okay, good job. This is telling you where your causes come from. You could have a medication side effect. You could be like the postpartum, the fact that you're eating nothing but sugar, substance abuse. Alcohol is a depressant. A lot of times when you're depressed, you take alcohol because you think it's going to make you feel better, and then you have a super deluxe depressed on top of which you're toasted. Okay? All right. Suicide is the 9th lead of causing death. I'm sorry if I stand in front of that. Firearms are the most common method for both men and women. It used to be women took pills. Women have gotten smarter. If they really want to do the job, they blow their heads off. As you know from the news, a couple months ago, that man had lost his face because he tried to blow his head off. Sometimes your aim is off and you live. We would prefer you not kill yourself, just in case you thought I was advocating for suicide. The men, like we talked about, are more lethal. Older people are more lethal. Once you hit 60, if you talk about suicide, take it a lot more seriously than an adolescent. Adolescents' hormones come and go. I can talk about suicide today as an adolescent and tomorrow be all chipper and bouncy. If I'm 65, 60 years old and talking about suicide, I'm much more likely to say my life is over anyway, blah, blah. Now I say, hey, you got 30 more years, you could have a lot of fun. But at 60, when they talk about suicide, it's much more likely they'll do it. Oops. So the risk factors, as you can see, are the depression for sure, the alcohol and drug abuse, because it takes down your impulse control. Okay? Today I talk about suicide and I'm sober, then I can think about all the ramifications of what will happen if I actually kill myself. If I'm toasted, I don't care about the ramifications. I can't even say it. All right? So that's much more likely, and that's why sometimes you'll have people that get hospitalized short term, and then they get clear of the drugs and alcohol, and they get to get out of the hospital fast because now that I'm clean, I get out. Or they say, look, you've got a long-term problem, Lisa. We can't let you out because you're going to start drinking as soon as you hit the door. You're going to get suicidal again, and then we're going to have to bury you, and we'd rather have you around to torture. Okay? Shoop. If your people are talking to you guys about suicide, that's a good thing, but you want to make sure you let people know so you get support and they get to talk to their therapist right away and deal with it and assess how serious they are. Your job is not to have to worry about how serious they are. Just take it as a serious thing, even if every time you come to visit me I talk about suicide. Feel free to call your supervisor every time and say, Lisa's talking about suicide again. She sounds like she did last week and the week before, but I just want to give you a heads up, okay? Because maybe it's time for me to get my meds adjusted, maybe it's time for me to see my therapist more often, or to find something else to do with myself. If I don't find any value in the world, then that's more likely that I might commit suicide. If all I talk to you about is the dead animals I see, the death, 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 that's a worry for you. Also, you'll be happy to know that if I've been super depressed for a long time and nothing's really changed and suddenly I'm happy and calm, I may have decided to off myself and not share with you, okay? So that's one of the warning signs that you guys who see them daily can say, look, I see Lisa every day. She's always whine, 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 suicide, suicide, suicide. And yesterday and today, she's all like happy and calm. What's going on? So that they can say, holy buckets, maybe something has changed for her. Either she's gotten happy, yay, or she's decided to do it this time and she's not going to share with us because she doesn't want us to stop her. Blah. I had one of my kids, I will only share stories from people that live in Wyoming or Colorado or Oregon because everyone in North Dakota knows everyone else, just so you know. So one of my children made a lovely plan, had himself a guest list of who was coming to his funeral, had that all set up. His teacher saw it, so his teacher called his parents called me, we hospitalized his little butt. So you do want to pass it on. If the teacher hadn't told the parents hadn't told me, we don't know if he would have decided to do it or not. But the fact that he was making his guest list and figuring out if he wanted flowers and all that crap is a bad sign, okay? So share, because you guys really do see it much faster than the rest of the universe, okay? Oh, there you go. And if I give you all of my best stuff, that's not a good sign either. Okay, because that means I'm clearing house and you've always been kind to me, so I'm going to give you my special thing. And you've always been kind to me, I'm giving you my special thing. You've always been kind of mean, and I'm going to tell you to fly the bird, you know. But I'm clearing house, I'm making arrangements. All right, major depression. You can have it one time only in your life. Those are the people that are lucky. If you're going to get major depression, let's go for single episode. All right, otherwise you have it recurrently, periodically. It could be years apart, it could be every few months, it could be we don't know how often. But it just means you've had it more than once in your life. All right, in order to get the diagnosis, we're going to go through our happy little book. It has to happen for at least 2 weeks solid. Okay, if I'm only depressed severely for 3 days, that's going to give me a different depression diagnosis. If someone comes to you and you know they've got major depression, you know they've been feeling this way for a while, if they are kids, some of your acting out kids are not just acting out, they're actually depressed. Okay, and so that kind of, do you treat them any different in terms of trying to set clear limits? No. But it gives you a little more distance in the heart to say, oh, wait a minute, little Janie is, you know, flipping me the bird, not because she's a little crazy crackerhead, but because she's depressed. Okay? If they stop being interested in stuff, I quit the swim team. I don't want to do anything anymore. They have appetite and sleep disturbance. They can either overeat or undereat. They can oversleep, undersleep, do a combination platter. Some of your people will not be getting out of bed. You guys will be coming there in the morning to help them get up in the morning. They'll be setting their therapy appointments for 10 o'clock in the morning because they want to have those people up and moving. okay? The lethargic, you gave me that one, or agitated. There's agitated depression where they're all bouncy and they've got a lot of energy. And those are the people that a lot of times will attempt suicide because they've got the energy to burn anyway. They feel worthless, guilty, hopeless, suicidal. All right, dysthymic disorder is your low-grade depression. All right, those are the people that are kind of like the sad sacks. Eeyore is your classic dysthymic disorder. All right, nothing is quite right. All right, something happy happens and it's okay. Something great happens and it's all right. You know, something terrible happens and of course, why wouldn't it happen to me? Everything terrible happens to me. Am I loud enough for you guys in the back? Are the front people's ears blowing out? Okay. Chronically depressed, in adults it has to be for 2 years. In kids it just has to be for 1 year. All right, they cannot have already had a major depressive disorder. You guys don't care, but trust me. Now, you can have someone with both dysthymia and major depression because if I've been dysthymic and diagnosed with that and then like 3 years later or 6 months later I get major depression on top of it, I can have both. I just can't do the reverse order. It's hard for me to make any decisions. It's hard for me to concentrate. And I don't like myself. Early onset is before 21, so that's your kids. And after 21 if it's late. Depressive disorder, NOS, is your catch-all. It is your premenstrual dysphoric disorder. Who knew it had a term, okay? Minor depressive disorder, recurrent brief depressive disorder, post-psychotic depressive disorder of schizophrenia. So basically you're having major depression right after you've finished your psychotic episode and are just on the upswing from your psychosis. Then poop, your mood goes out and now the world really sucks eggs. Or you can also have major depression right as you're in the height of your psychosis. All right, and so then you might incorporate your depression into your delusions. They had on the news a couple weeks ago or a week ago that man that killed his children. He went psychotic while he was major depressed, and so he knew that the world was going to end, and so it would be better for his children if he took them out. So he did. All right? So you do want to find out from people, I'll tell you this again, but you want to ask them if they are hallucinating, which we'll get to. Ask them what they're hallucinating, what the voices are saying. You do not want to have someone whose voice is telling you to kill you. All right? Not likely to happen, but best to find out. And usually people will tell you, or they won't tell you, and then you make sure you tell, once again, your supervisor and say, hey, I asked Lisa what the voices were saying. She gave me a filthy look, grabbed her little knife, and walked away. Well, something's bad is happening in my universe, and somebody needs to find out what it is. All right? Your job is to report that I'm going a little bonkers and you need to help me. All right? If you have to, you'll wrestle me to the ground, but hopefully you'll just, pass the word up, the line of command. Whoops, did I go backwards? Are we all good? All right. A lot of times we do the medication, blah, blah. That's why they're asking you if you're drinking when you're on medication because of the counter effects that it has. There is ECT. It's no longer like cuckoo's nest anymore. It's not done a lot here in North Dakota. It is done more than it used to be. It's kind of the new fair hair child. They do more minute little tiny stimulation in your brain to get your production of your neurotransmitters up. Oh, he's coming to me. Hello. Oh.
Better.
Thank you. Thank you, guys. Okay. Doot. All right. I'm a therapist, so of course I think everybody should have therapy. A lot of times we do a combination of the medication and the therapy together. Oops. And you'll graduate from one or the other. All right? Or you'll graduate ultimately, of course, from both, usually. But some people are in medication monitoring only. It's just that their body's not producing the right neurotransmitters, and all they need to do is maintain that medication, and their mood is stable. All right. Whew. Then we have our bipolar disorders, which used to be called manic depressive. We changed the name because we want to keep people confused. That is my theory, because that's just what it is. Okay. What do you guys expect? What do you guys expect from bipolar? Oh, pardon me for a mere moment. Didn't you guys do well on depression? Okay, bipolar. Okay, any other expectations? Anybody worked with bipolar people? Raise your hand. I will not call on you. Okay. Anybody that worked with them or heard about them that has something else they want to share, if they are shy, they could share it with their neighbor. All right, highs and lows it is. All right. All right, did anybody watch ER and see Sally Fields portray the Abby's mother with bipolar? They actually did a very nice job of bipolar with her. When she was on her meds, when she was balanced, she was charming, adorable, cute as a bug. When she got off her meds, when her meds weren't working the way they needed to for her anymore, she got psychotic, all right? When someone is in full-blown manic stage and they go psychotic, which a lot of them do, there is no way, without knowing someone's history, that you can tell the difference between their psychosis and schizophrenic psychosis, okay? You have to wait till the psychosis is over with medication, and then you do the interview and you talk to them and you find out what their diagnosis is going to be. Or you talk to the family members and find out what their diagnosis is. All right? They also had a film with Richard Gere. I don't know if people saw that, where he did a pretty good job with bipolar as well. Bipolar is, Patty Duke has it. A lot of people have it. A lot of people live really productive lives with it. It can really be maintained. The problem that you face is that when you are bipolar and you're starting to rev up for manic, the early stages of mania are fun, okay? You got energy to burn, you got creative juices flowing, you're sure the world is your oyster, and who would like to get rid of that feeling? You look too happy, you have got to take medication. It's like, yeah, right. I'm supposed to take medication because I feel too happy. Okay, so that's where the bipolar trap is, okay? They do not like the lows, they do not want to become suicidal and depressed. They do not like the supreme mania that comes to a lot of them and become psychotic. People don't want to be psychotic. But the upward swing, are you kidding me? I'm too happy, take a pill? Right. So that's the problem you face. All right, manic episode, there we go. Distinct period, elevated, expansive, or irritable mood. All right, a lot of your bipolars are grumpy. All right, when you go to me day after day and you're saying Lisa's on a grumpy streak, don't just think I'm on a grumpy streak. You already know I'm bipolar. Tell my therapist, tell your supervisor, tell somebody, because my meds are not working like they should be. All right? If I'm grumpy one day, hey, who's not? And it lasts for at least a whole week. Unless, of course, I've gotten psychotic and you've had to put me in the hospital. All right? Then they should bring me down much faster. Thank you. All right. And here's where we have our mix and match recipe book. All right? You're going to have some of these you know what they're called. Symptoms, thank you. In combination, you've got grandiosity. All right, somebody at the Wyoming State Hospital is in Evanston, in case you don't know. It's on the highway, because we always build our state hospitals on the highway. There's something about those. And so every single truck that drove by was one of his. He owned it. He was a very wealthy man, and he was very happy about owning all the trucks that went by. All right. Not so good when he was on the street telling people and getting fistfights because you said, no, you owned the truck, because he owned it and he wanted you to stop driving for him. A lot of mania people act the same way as your meth person does in terms of not needing sleep. It is not the person that has insomnia that only gets a few hours of sleep and feels tired and bedraggled. This is your person that gets up at 2 a.m. to clean the house and has energy for the whole rest of the day. Because why should you need more than 1 or 2 hours of sleep? Doesn't everyone just need 1 or 2 hours of sleep? And by the way, I wrote this short novel. Half of it was gibberish, but it was very good. And I made this painting, and I cooked a cake for you, and blah, blah, blah. Okay? They talk like I do. Pressured speech. Woo! Okay? I can demonstrate. All right, flight of ideas. If one idea is good, 65 or better, right? So I start talking to you about the fact that I see that you are wearing blue today. Blue is a good color. Did you know that the lakes are blue? Lakes are really pretty. Aren't they pretty? Oh my gosh, the sky is blue too. And I had a blue ball when I was a child. And you're just like, woo, where did that come from? All right. And excessive involvement in pleasurable activities. These are the people that will go out and gamble their life savings away. They will spend, spend, spend. They will have sex with anything that does not run away from them quickly enough. Okay. Okay, I will go to Las Vegas and I will lose my life savings, and if you give me your ATM card, I will lose yours as well. All right. For bipolar 1 disorder, you have to have had one manic or mixed episode. Did we pass mixed episodes, or did I forget to put it in the right order? Oh, all right. Well, mixed episodes are, of course, a combination of mania and depression. All right. When I'm a bipolar 1 disorder, I have big problems, and I could or have psychotic symptoms, which I consider big problems too. All right. They list them by type. You can have bipolar 1, most recent episode depressed, most recent episode manic, most recent episode mixed. Okay. B, there we are. And for my mixed episode, I have to have had mixture for at least a week. And every single day for a week. Okay? I get wound up in front of groups, as you can see. I am not going to qualify for bipolar, although some of you are diagnosing me. I can see that. All right. Bipolar 2. She was diagnosing me. All right, bipolar 2. Hypomanic episode. That's actually what I'm displaying is hypomanic kind of stuff. At least 4 days of elevated, expansive, or irritable mood. Notice it did not pass the magic button of a week. Okay? You can't be psychotic if you're hypomanic and you're bipolar 2. These are the bipolars that have an easier life because they never go psychotic. They never have to explain to people why they killed the puppy because they thought the puppy was possessed by the demon. All right? And it doesn't have to be severe enough to cause marked impairment. It causes some impairment, but not to the place where you're thinking, where's the nearest phone, and should I call the emergency ward and hospitalize Lisa right this second? Okay? Blah, blah, blah. You can have 1 or more major depressive episodes and 1 or more hypomanic episodes, but never had full-blown mania. All right? And then you're in the lovely family of bipolar 2s. Cyclothymic is, cycle. Very good. Your mood fluctuates. This is your typical adolescent. They do not get diagnosed with cyclomania, but they all act a little cyclothymic. All right? You've had them in your homes, either as your own children, as yourselves, or your visiting children. Up and down they come. 1 minute they're happy, the next minute they're crying. Oop. Uh-oh. I did something wrong again. Double. Oh, there you go. All right. Bipolar usually actually begins in adolescence or early adulthood. I am old, ancient, decrepit. I'm just letting you know. We used to never diagnose any child with bipolar. All right? They now will diagnose little kids with bipolar because they now feel that you can actually see the bipolar and see the mania, etc., at an early age. Okay? But still, the typical person doesn't get it until they're a teenager. That's why a lot of kids go away to college and then have huge problems. They've held it together. They seem to have little edginess, but nothing that the parents are like way crazy worried about. And then the kid goes off to college, and what did that college do to my poor child? My child has now got huge mental health issues. 2 million Americans are affected. All of them go into the entertainment field. Talk to any of them, they'll tell you. Family members often have to cope with serious behavioral problems. That is why you have a lot of support groups. That's why the Mental Health Association is important, not only for the person with a mental health disorder, but for their families. It's really hard if my sister is going to come through and be manic every few months and try to, break into my house to steal money because she knows that this time she's going to win when she gets to Vegas, and all she needs is money from my house to get to Vegas to win the big time. Okay? Hard for me to remember that she's my sister and I'm supposed to love her and not kill her, right? All right. Lithium was the big thing. They also have some Risperdal. They have different medications. Bipolar disorder, they have down in El Paso, you'll be happy to know, more natural lithium salts in the water. So the medical doctors down there have to take that into account when they do their lithium levels. Because it takes less dosage down there because you're drinking a little lithium. You could encourage your manics to move down, get a little lithium without having to take meds, Oh, now I've really done something wrong. All right. All right. Now wait a second. All right, I lie. Help me. Okay. All right. I really do need help. Hit 5? F5. And we're back to the beginning. And now what do I do? My helper person. Thank you. I want to go to whatever screen it was on. We were in bipolar.
Mixed, or were we past mixed?
We were past mixed.
Bipolar 2?
Yes. All right. Thank you very much. Do, 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 do. All right, we're going to have a quick review. Because I think we're at our activity. Whoop. Oh, antidepressants, there you go. Psychotherapy. One of the things you're doing with psychotherapy is you're helping the person to accept the fact that they've got diabetes of the brain. They are not going to willpower their way through it. They are not going to be able to get off of their insulin. If they've gotten to the place where they've got severe enough bipolar that they need medication, they are primarily lifers, all right? It is hard to tell someone that they are probably going to have to maintain a medication for life because a lot of people worry that they're not going to be creative. All right, you've got a lot of artsy people. I had a painter that was sure that she didn't paint as well when she was off her meds. Not true from my uneducated eye. And the problem for her was she went into psychosis. No one paints well as a psychotic. No one writes well as a psychotic. You cannot organize your thoughts well enough. Okay? But when you're cruising to get off your medication and you're starting that mania high when it's the fun part, you don't remember the psychotic part where you went bonkers. You remember the cool feeling of the fact that I got up at 2 a.m. and had energy. I got all my painting done, took care of the children, and pressed the coats of everyone around me. Okay? Long-term preventative therapy, blah. Other mood disorders. All right. Then we're just going to go through a bunch of mood disorders you might hear about. There's due to a general medical condition, which is what? We'll look at our notes. But, oh well. When you have a medical condition that's the reason you're feeling depressed, okay, it's not that I'm actually depressed about anything, but one of the symptoms of my medical thing is depression, then that's what they're talking about. So it might look just like major depressive, it may look like all of the others, but actually it's like Huntington's chorea, AIDS, brain injury, those kinds of things. It's going to have to, it may need to have an antidepressant on top of it, but it's not really so much of a therapy position as it is a position of you need to have a good physician help you out so that they can help the person out, all right? Then there's bipolar NOS, which is, of course, in the bipolar family. NOS is not otherwise specified, and it's basically you're in this family, we know you're in this family, but you don't quite meet any of the particulars enough, all right? Then there are the people that, because of the drugs or alcohol that they've taken, their mood has changed. All right? I had a depressed homicidal kid in Wyoming who was depressed and homicidal because he was a glue sniffer. Good job. So I didn't know exactly what was going on, but it was a sudden onset. So we hospitalized him and I had the parents do a room search. And he was busy sniffing rubber cement. Do not sniff rubber cement. Fries your brain, not a good thing. Steroids. You know, you've heard about the steroid rages, all right? And the meth people, etc. Bloop. Bloop. All right, your mood disorder can have psychotic. We've talked about that. They can have catatonic. Those are the immobile people. Okay? Those are these people. And they can do it for a month. It's very exciting. There are a lot better medications for that. You're not as likely to see it. You're going to see it more often at the state hospital. You guys are probably not going to run into it in your practice, but they may have had a history of catatonia, so they'll give you that. Melancholic is Eeyore. Everything is very sad and blue. Seasonal pattern, those are the people that are using the sad lights because they need the sunlight, they need the vitamin D. Is it Denmark, I think, has sad lights in every coffee house. Because they feel like because they have such a shortened season that every single person there tends to be depressed, so they're just going to give you all a little sad light as you walk in to get your Starbucks coffee. You're also getting a nice little bit of sad light for you. Okay, they rate the severity. You probably don't care, but they do. Mild, moderate, severe, partial remission, full remission. Depends on, the remissions are, of course, how long you've not been feeling sad. The severity is, severe are going to be the people that are suicidal and have a lot of symptoms. The mild are going to be maybe on the way out of depression, or maybe they're lucky and they only get at a mild level. It is still an unhappy time. It is still enough, not just I broke up with my boyfriend of a day, okay? All right, things to do. Feel free to help them sort out their thoughts, all right? And to say, well, do you really think the whole world will end? You know, well, no. All right. If they're psychotic, let's not go into it. But if they're not psychotic and you're just trying to help bounce off ideas and help them explore what's going on, remember the last time you were happy. Remember how good it used to feel. We can get you back there again. That's what your meds usually do for you. That's what your therapy usually does for you, blah, blah. Acknowledge the fact that they're in pain. Feel free to help them set reasonable goals. Feel free to talk to your supervisor about what the goals are. Talk to the client about what the goals are so all of you are on the same page, okay? My goal may just be that I want to get up before 10 a.m. And you, as my case aide, may be getting there at 9:55 or 10:05 to make sure I'm up, okay? And you may have talked with the supervisor and your therapist people about the fact that Lisa's real goal is to be dressed and beautiful by 10:30. So we're getting you there at 10 so you can get her up and moving, because at 10 she'll probably be all sleepy and not come to the door at first. But as progress is made, at 10 o'clock I should hopefully ultimately meet you happy and dressed, and then we'll find a new goal for us, okay? Kind words. Boop, boop, boop. I think we covered all this pretty much, yes? So, all right. So listen and be cute as bugs. All right. With your mania, feel free not to be too close. They may need a little space. All right. Be calm. The louder I am, the quieter you get, because I love to hear my name. So say my name because I want to hear it. It has to slow me down a little bit because you must have been saying something fun that I'm interested in. Okay. If you talk quieter, I'm going to slow down a little bit. But enough, hopefully. Make sure to remind me that this is just a stage I'm going through, that I can get through this, that this is not the time for me to be making those big investments that I'm thinking are so cool. Okay? Set limits that fit for you guys. All right? If I want to run to the store and then I think you guys should take me here and take me there, well, you're not there to be my chauffeur and drive me all over from here to there, yes? You can say, well, look, today my job is to help you get dressed, and my job is to help you get to the doctor or help you fill out these forms. And it sounds like you're going to be talking to your therapist about those other things you want. Okay? You can refer them back. All right? You don't have to get into big arguments about the fact that I do not own every truck that goes past me. All right? I'm not going to listen. I'm going to think you're rather stupid not to know that I own them all. And then all it's going to do is get me more agitated, because then I'm going to have to explain to you how perfect I am. All right? So it's sidestepping the power struggles as often as you can. Bloop. The controlling of the environment, if little stimulation is possible. Do not take me to the mall. I do not want to go to the mall because I will have to run through the mall and see everything. All the bright colors will entertain me. All the people will entertain me. You think I was manic before you picked me up. Now I'm really manic. Feel free to take me for a walk, because I'll get rid of some of my energy. I'll be able to maybe focus more on talking with you all, because I'm going for a stroll and getting some exercise and getting rid of some of that energy. And of course, rat me out. Do not let me wander around in my mania, and do not ever assume that the therapist knows what the heck they're doing. I'm a therapist. Trust me, we know nothing. If you do not tell us, we will be clueless. All right? And I know. Long ago, back in the olden days, when I rode my horse and carriage off to work, I used to be residential care staff for emotionally disturbed adolescents. I assumed the therapist knew everything. I was wrong. And so the supervisors would read the logbook. Then the supervisors would tell the therapist what was going on in an abbreviated fashion. Okay? I had to cover for the psychiatrist because the psychiatrist told my kid that she just psychically knew that the kid had wet the bed. Well, I had told my kid, hey, I rat your ass out because, pardon my French, I ratted your butt out because you wet the bed and then you became suicidal, and then we spent 2 hours in the middle of the night talking. So I told you I was going to put it in the log. I put it in the log, but maybe your psychiatrist didn't have a chance to read it and just psychically knew. But I'm like, so sometimes therapists, we make mistakes. We can't help ourselves. But if you don't tell us what's going on, if it hadn't been in the logbook, there's no way the therapist would have known to talk to the kid about being suicidal last night in the bed. Okay, she's 15. It was very embarrassing. Mood disorder activity, yay! All right. Yes, it's true. Groups are happening. All right. What we're going to do is, y'all are at tables. The front row table is going to turn around and talk to the back row table. Yes, it's true. And vice versa, all the way down the line. We have an uneven number So you guys that are stuck wedged way in the back get to pull up and talk to the other people. What we're going to do is role plays, and yes, I know, sucks eggs. So we're going to do modified role plays. We are going to have you guys, have 2 of you be the client, all right? And you get to be a mood disorder, your choice of what mood disorder. If you do not have the handout, let me know, because those are where your symptoms are coming from, because I did print out handouts for that, okay? Then the rest of you, which will be about 4, I get to be the mentor case aide and help the poor client out. Does that make sense? What we want to do is we want to practice what kind of symptoms are you going to be seeing, and what kind of responses are you guys going to need to do to help your client through this so that they can work on things. Yes, don't all move at once. All right, front row, turn around. It's the handouts you've been looking at, because those have the symptoms. Oh, it's the big thick one. The big thick handout is mine.